Hello and welcome to Q&A. I'm Marcia Boyles, your host, and I'm delighted today to give the beginning of the third in our series on memory. My partner in this particular series is Kathleen Taylor. Welcome, Kathleen.
Thank you.
We're delighted to have you. Kathleen is our Green Spring social work manager and has the answers to almost every question that we can think of on memory. Kathleen, let's just recall a little bit about what we've talked about here in the past, these last two programs. And for folks who like what I'm talking about here, if they'll watch when we do reruns of these, if they'll watch the first two, they can pick up on what we're talking about here. We talked first about the memory fitness activities that we have here at Green Spring. We talked a good bit about the support that's available for care partners of those with dementia. We talked about factors that contributed to memory issues and dementia, such as age and exercise. We also talked about reversible or temporary dementia that is caused by stress. And then lastly, we talked about neuroplasticity and cognitive reserve, defining those terms and talking about their significance. So those were in our first two programs.
Yep.
We still have a handful of questions that we hadn't answered, and so we're doing this third program. Now let me also explain to folks that these questions came, some of the questions I think had been provided to you, some were provided to me, and I came up with a few of my own. So this is a combination of questions that we get from residents. Now, here is the first question. Why do some people, oh, excuse me, I'm on the wrong page here, literally. I have a friend with whom I go to lunch and go grocery shopping every week. She drives since I gave up my car years ago. She clearly is getting extremely forgetful. She forgets all kinds of things, conversations that we had the day before, even sometimes asks me many questions in the course of an hour's conversation, asks the same question over and over. Now my question is she safe to drive?
Short answer, probably not. Probably not. Do you feel safe driving with her? Do you notice problems when she's driving?
Sometimes she seems to be confused where she is and I point her in the right direction. But mostly we go to the same stores.
Right. And I think that because she is going in the same to the same places, taking the same route, probably like the idea of the risk isn't really associated to getting lost. The risk is more, I think, associated with the fact that her processing probably has started to slow down because you can see word finding problems, not remembering conversations that you had just a few minutes before, that sort of thing. Is just sort of saying that in general, her ability to process information is not as effective as it used to be, and where that really becomes a risk is her being able to problem solve behind the wheel of a car.
Yes.
So if something were to happen quickly, somebody were to go through a stoplight or something like that, she would just not have the capability to respond quickly enough to protect you or herself from an accident. So, so for me, it really has more to do with reaction time, and just really overall slowing of her processing. So I think the next question that comes up then is, well, what do you do about it?
Exactly.
And because she is your friend, you're going to want to have that conversation with her, and maybe suggest to her that she go see her physician to be able to just openly and honestly have that discussion about whether it is safe for her to drive anymore.
Is there a driving assessment test available?
There used to be. We used to have Viva on campus, and Viva had a nice program where you could do an assessment in terms of some of your, it had to do with reaction time, peripheral vision, all those things that come into play when you're driving, but we don't have it anymore. And I don't really know of anything else in the area that replaces that. So, so I think that it, really is up to the person to, I know people hate the idea of giving up their
car, of course.
It's really, really hard because it's symbolic of so many things in your life. But it's also a weapon. And if you can't respond appropriately and safely, then you really are putting not only yourself but others at risk. And I think that that's something that most of our residents understand after they get over that first emotional no.
Exactly.
But that, to be able to talk to their families about that, talk to their friends. If you're driving with her and you perceive that, it makes you nervous being in the car, or you see that there might be problems, to just be able to let her know that.
All right. I suspect the individual is a little bit concerned herself.
That's a good sign.
Yes.
Yeah. I mean, the other thing is, too, that if you are aware that somebody is driving and they are probably not safe, then we can contact the Department of Motor Vehicles. Our physicians normally do that, send a letter of concern to the Department of Motor Vehicles to have the person's license revoked. And at that point, they have to go through they have to go back and get their license again.
Oh, take the test again.
Take the written test, do the test out on the road, that sort of thing.
All right. Okay.
So there's a process, but hopefully, we really do hope that people kind of do what's right.
Well, and I think you always worry when the person is by themselves that they're going to get on the road and get lost.
Oh, well,
and not be able to find their way back.
Get lost, go down with all these crazy roads,
One-way
go down
roads,
the wrong way. There's a lot of things that can happen out on the road.
Particularly in an area like this with the traffic.
Oh my! But I know people do. I've seen people that they make accommodations. They don't go out at night anymore.
Right. Exactly.
They don't go any place that they're not familiar with. They go with somebody else, and all those things are good things to do. And I think that they can extend your ability to drive for a period of time. But at some point, I think it's probably best to consider not doing it anymore and taking advantage of all the different services that we have on campus that can get you where you want to go.
Yes, thank goodness for them.
Absolutely.
All right. Thank you. Now, this is a question that is loaded.
Thanks for warning me.
Gosh, it makes you really want to answer it, doesn't it?
Can I go now?
Right. Okay. Why are people with dementia allowed to move into Green Spring independent living apartments? Don't new residents have to meet certain mental and physical standards any longer? It was different when I moved here 14 years ago. Do the social workers decide who moves in like they used to? Now, this is clearly a question from an old-time resident,
right.
And I'm sure you hear this same question multiple times.
We do. Some of they used to have different tests when I moved in. I think they've kind of created a mythology a little bit in terms of what people had to actually do.
Yes, they were toting 10-pound bags of something, or
kitty litter or something.
Kitty litter, right.
I don't think that those were our most refined methods for determining whether people would be successful moving in or not. So if that's the case, I say that's a good thing that we have actually changed. But I think that the perception is that it used to be harder, and somehow we've lapsed in how we make a decision about how people are going to fit into the community or not. So I guess one of the things I sort of want to say is that really it's not the social workers that make the decision about when people come in or if people come in. We have a team of people that are involved. If there's
Well, now wait a minute. Let's stop just for a second. Don't the social workers provide each potential new resident with a cognitive test?
Yeah, we do some assessment. And currently part of the assessment includes some form of testing on cognition. But we are doing the assessment, then if the person might be, in a gray area in terms of whether they look like they're going to be able to fit themselves into the independent living setting, then we go to a committee decision. So it's
okay.
So it's
so
not,
they take that test score, quote unquote, into consideration.
well, it factors in for sure. I think that. First of all, dementia as a diagnosis doesn't equate with a person's ability to function. And I think that that's something that people might think. If a person has a diagnosis of dementia, that therefore they would not be appropriate for independent living.
I think that is definitely an assumption.
Yeah, and that's. I mean, a diagnosis has absolutely nothing to do with a person's ability to function, because of all the things that we've talked about before in terms of neuroplasticity and cognitive reserve and just ability to adapt. So I can't get hung up on the dementia diagnosis. And plus, I don't think a lot of times that people actually understand that a person may not have a diagnosis of dementia. They just might have short-term memory loss because they're not privy to that person's private healthcare information. They're looking at, looking at a very short snapshot of somebody and noticing that they maybe can't remember what day it is and thinking therefore that they have dementia, which is not really the case. So people are coming into independent living with some degrees of memory loss, but there's been the determination that they're going to be able to make that transition and be able to function based on what we know from a total or a holistic perspective, what their capabilities are.
Does that include? Does the holistic approach to whether they can function or not also include the presence of a spouse?
It may have to do with, is there a spouse or is there family in the area? I mean, it's just a lot of, what are the social supports? Those are the things that we talk about. It's what are those person's social supports? Were they a social person prior to coming in? Do they like to get out and socialize and meet new friends, or do they tend to kind of keep to themselves and getting out with other people might be difficult for them? So there's just so many, it would take the whole time that we have talking about all the different things that we look at.
Who makes this decision then? Who would be on such a committee to make a decision?
We have the independent living social work team, including myself. We have members from marketing, including the marketing director, and we have administration. So that can be our associate executive director, or sometimes it can be our executive director. So we pull in a group of people, who can really make an informed decision about whether that person would be able to make a good transition. And of course, we have no crystal balls. And what I would say too is that we think that people are going to do great, and then they don't do well, And that's apart from cognition. That's just some people don't make an easy transition into this environment, and we would not be able to guess it ahead of time.
All right. You have also indicated in the past that sometimes folks coming in on the cusp, as it were, that the stress of moving in also can exacerbate the whole memory issue.
And that could happen for people that appear to be fine too, because as we've talked about, stressors really can impact your cognition, and sometimes it's temporary. Sometimes it's again that cognitive interference that we talked about, that all of the stress or maybe anxiety of making that move really gets in the way of people being able to focus. And so they can't remember how to get to the dining room. And it's not because they can't learn, it's just that they can't focus at the moment. So give them a couple months to settle in, and they could be doing perfectly fine. So it's just, it's just like everything in our lives. Sometimes things take time, and we really don't have a crystal ball when it comes to people, but we really do want to give everybody possible the benefit of the doubt, because when all is said and done, if they're here and they need more help, we have this wonderful continuum of care that we can provide all the resources that person will benefit from that they wouldn't have had if they were outside in their own home and didn't have those resources.
Kathleen, that actually is our last question, and why don't we skip over to that and talk about our next to last question. Why don't we talk a little bit about that? What happens if the individual does need to transition over to Garden Ridge? What kind of support system, what kind of facilities do they have that would be appropriate for somebody with dementia?
Right. Well, we have a memory care unit, which is our dedicated dementia unit for people that really have some pretty significant symptoms related to dementia. When we're trying to help decide what appropriate level of care would be, a lot of times, well, all the time, we do an assessment which is for all levels of care in Garden Ridge. So we're going to look at traditional assisted living, our memory care unit, which is assisted living as well, and then also our long-term care nursing unit. And there's going to be an assessment. We do some assessment on the independent living side, then it's reviewed by the team over in Garden Ridge, and then they're going to make a decision about what is the best level of care to meet that person's needs. So sometimes even if a person has memory loss, just the structured environment of a traditional assisted living unit can be sufficient.
And folks can move from one level to another once they're over there.
They can do that, and often they do. Though we are trying to broaden, for example, in our traditional assisted living, we're trying to broaden our capabilities to avoid people having to move any more than they would absolutely have to, because that's such a disruption. So we really want to make sure that if we can manage that person's care needs and not have them move, then that's the best.
I see. All right. So there are some folks in assisted living then that are clearly have dementia.
Well, or have some degree of memory loss, but because perhaps they've been there for a long time, and so that's their really familiar environment, and because there's all those supports that are available, and the nursing staff gets to know them so well, they can accommodate to that setting, and be perfectly fine.
All right. You have situations where if you have a person with sort of severe short-term memory loss and or dementia, and the spouse that was the caretaker becomes ill or in some way incapacitated, can folks go over to Garden Ridge then on a temporary basis?
Yeah, yeah. There's a couple of different approaches for that. One is if there's a care partnership and one of the partners, the one who's been the caregiver, gets ill. I mean, it can be any number of different things. Sometimes that person ends up going to Garden Ridge because they've had a hospitalization.
Exactly.
And then the other person is in their home and maybe needs to have some support to be with them, or maybe not 24 hours. So the social worker will go in and work with the family to be able to figure out, how much support is sufficient to be able to allow that person to stay. Again, that's the goal. If a person can continue to stay in their apartment, in the place that's familiar to them, that's always the ideal. Sometimes we can just put home support services in place. Sometimes it might be 24-hour care, but that's what the family determines is the best choice, is to allow that person to be in their own home, sleep in their own bed, all of those things, that it would be less disruptive. But at other times, Garden Ridge, going to one of the nursing floors can be on a temporary basis, something that is doable as well.
So there's lots of flexibility in this system.
Yep.
Amazing. Just a lot of support.
There's a lot of support. Yeah, absolutely.
All right, here's our last one. My spouse is getting very forgetful, and Alzheimer's runs in his family. He refuses to go to the doctor, to the medical center. How in the world can I persuade him to do something? We simply don't have any diagnosis. We have no treatment. I don't know what to do.
Wow. Well, sort of depends. So he's just forgetful.
You know, I can't tell from this question. She simply says he is getting very forgetful and Alzheimer's is in the family.
And he refuses to go to the doctor?
Uh-huh.
Why
Flatly refuses.
Oh, goodness.
And also, as I understand it, will not discuss any possibility of his having short-term memory loss.
Well,
one might say that he's in total denial.
doesn't want to go there. Well, I guess one of the things that we could...
Do you see that this happens sometimes?
I do see that happen.
Must be very, very frustrating for the spouse.
Well, it really has to be. Now, I want to add, because I think I told you about this before. I can't remember the name, but there's actually a condition related to having dementia, which is that person, because of what's going on in their brain, is not able to understand that they're experiencing
Doesn't recognize
memory loss.
that they're...
Doesn't recognize.
You told me about
Yeah.
that. That is astonishing.
Yeah.
So when they're in denial, they really don't know.
Yeah, it's not denial.
Right.
It's just not knowing.
Not knowing.
So,
Okay.
so we won't judge in terms of what that
Right.
what that person's
Exactly.
experiencing.
Don't know what the situation is.
But I think maybe the first step could be, if we can't get them to a doctor, is if there's, I like the idea of having family involved. So if there are children or very close friends, that the spouse could maybe, do a little intervention with their person and family or friends, and just talk to him as openly and honestly as possible about what they're seeing. Perhaps that might persuade them to be able to see the benefit of seeing a doctor. And I guess, or getting a social worker involved too is always a good idea. I think that sometimes, as we've talked about as well, it might not be dementia. It may be any number of other things, including medication, including other kinds of physical diagnoses, stress. There's lots of reasons why a person might be having memory loss that doesn't have anything to do with having a dementia diagnosis. So part of what the tactic that I would take if I was going in is, it's better to know than not know, because number one, if you do have dementia, there are treatments that they can initiate, and they can also do a workup and determine if it's not dementia, and then there's going to be treatments for whatever is going on as well. So again, better to know than not know. So I would just try to, persuade that person that sticking your head in the sand is probably not the best response. And then I don't know, in the long run, if you have somebody that at some point it's going to become an issue that sort of you can't deny, and it might, but in the meantime it might be more about supporting that caregiver.
Okay, that would make sense. And of course, your approach is a rational one.
It's a rational one.
If the individual is really lacking in rationality.
Well, that's why I asked sort of where they were as far as not being able to make good decisions, because impaired judgment is certainly, something that happens with dementia. And if that's the case, this is the tricky part, but they may be determined to not have healthcare decision-making capacity. They'd have to go to a physician to be able to determine that. But at that point, hopefully they have an advance directive, and the wife or someone else has a power of attorney that they would be able to kind of make some decisions on that person's behalf.
Right.
But that's like way down the road. That's not just in the initial stages when the person's really struggling.
Right. Okay, that would be the ultimate resolution to this. But in the meantime, certainly a lot of frustration.
Yeah, and I think just trying to figure out different tactics for being able to kind of reach that person who's really probably more than anything just terrified.
That would make sense.
Yeah.
So your social workers could also come in and attempt some intervention.
Yeah, absolutely.
They would be perhaps less threatening than going to the medical center.
Yeah, I think so. And we definitely have an approach that we try to definitely be not threatening and strength-based, and not judging in any kind of way, but just to try to listen to the person, and if they're frightened, to just try to figure out a little bit more about what's frightening them or causing them anxiety, and through that door maybe get to what the doubts are.
All right. Well, I think on that note, yeah, that's a terrific service when you think about it. So many folks are. I mean, we all have some fear about going into a doctor for anything.
Yeah.
And I can see where that really could be a hindrance.
Yeah. But we want people to make good decisions. So, that's our ultimate goal, is to, just sort of having anxiety, if we can help remove that so that they can then make that correct decision to go see the doctor and have that workup, then that's exactly what we're here for.
Well, I think that's a very positive note to end on here, Kathleen. We've gotten through all of our questions.
Yes.
Finally, after 3 programs worth.
Yeah.
And we were happy to do it. These questions, I think, have been very revealing, and the answers have been very revealing. Certainly, this is an issue that many residents sit and talk about. We all talk about it, in one fashion or another. I think practically every day.
Yeah.
So these have been extremely helpful.
Good.
Thank you. Thank you for doing this. And again, we will re-show the 3 as a group. I'm hoping on a weekend fairly soon.
Yeah, that's good.
So, thank you, Kathleen.
You're welcome.
And
thank you.
with that, we will close up today, and we'll look forward to seeing you next month.